Welcome to the intubation and endotracheal tube management session. My name's Carol Belanger and I'm going to talk you through some of the aspects of this intervention that you may see on the intensive care unit. We'll talk through intubation and endotracheal tube management. We'll look a little bit at some of the different artificial airways and their features that you may see. We'll talk about understanding the role of the nurse assistant during the intubation procedure, some of the safety aspects to be aware of. And then we're going to talk a little bit about appropriate fixation and observation pre, during and post procedure. Intubation you may or may not have heard of. It's placed into the windpipe or trachea through the nose or mouth. In most emergency situations it's placed through the mouth, and this is what you're likely to see in the intensive care unit, and we use this method to attach people to artificial respiratory support. There are many indications for why we might do this. Respiratory failure is the obvious one, and this is what you might see during COVID. Loss of airway protection might relate to a patient who's lost their gag or cough reflex by having a reduced GCS. Being over-sedated, being narcosed, or having a brain or spinal cord injury or peripheral nerve disease such as Guillain-Barré. These are all reasons why we might need to protect somebody's airway. Gas exchange problems we'll talk about in a later talk. Acute lung injury, lung contusion, muscle problems, airway obstruction such as caused by edema. And also if we might have an anticipated loss of airway control in a situation where we may have a worsening stridor, perhaps, or burns even. Principally, we're going to talk here about failure of oxygenation and about diffusion of abnormalities. We see pulmonary edema, alveolar aspiration, and an increase in dead space. These are all aspects that we need not to worry about at this point for C19 space, but you just need to be aware that these are the concerns that the intensive care clinicians will be having in relation to considerations for intubation. Basically, what we're talking about is a loss of airway protection, and that leads to a failure of ventilation, which leads to a failure of oxygenation. And that's at the point when we consider respiratory failure is a major concern and a need for intubation to protect the patient's airway and facilitate effective ventilation. So the first thing we need to do is assess. We need to think about our goals. And looking at the patient, we need to assess the risk of difficult, are they going to be difficult to mask ventilate? That's with a bag valve mask. Are they going to be a difficult intubation due to their anatomy or whatever clinical situation that they present with? So we're going to start with manual methods, and you're all very familiar with these in your day-to-day practice. And your manual methods would include head tilt, chin lift, jaw thrust, and then we progress up the scale towards simple adjuncts, such as an oropharyngeal or nasopharyngeal airway. You may well have seen laryngeal masks or laryngeal airways. These are called supraglottic airway devices, and we use these sometimes in an emergency situation pending a definitive airway, which would be described as an endotracheal tube. If we fail to insert an endotracheal tube for whatever reason, then we obviously need to think about needle and surgical cricothyroidotomy and tracheostomy. I'm not going to cover these in this talk, but it is important that you're aware that there is a scale of escalation to make sure that we've got an effective airway for our patients. Simple measures for the patient whose airway is at risk. You're all very familiar with these: chin lift, jaw thrust, and jaw thrust with neck extension you really must not do. This causes significant damage. There are ways that we can predict difficult intubation. You'll find that the intensive care team will be thinking about this if they need to intubate a patient. Those patients who are overweight with poor head or neck movement, poor jaw mobility, or those who find it difficult to open their mouth much, less than 5 centimetres. People with a receding mandible. We always watch out for people with beards because that's often a indicator that they've got a small jaw. And these anatomical differences can make things a little bit tricky when we're looking towards intubation. Here's some pictures that illustrate some of these things. This lady on this side, she's got a receded jaw, and that makes it very difficult for us to actually pull away and get a good view of the vocal cords, which is what we're aiming to do during intubation. This lady here has a large goiter, and that's very difficult also, but as the anatomy may be misplaced. Gentleman in the middle, he's got a very swollen, protruding tongue, and that edema may progress further back into the airway, and that does make things more tricky when we're trying to find the right place to place the ET tube. People with teeth like this also challenge, and those with poor mouth opening, as you see in this lady here. These are things that the intensive care unit will be taking into account in a fairly rapid fashion if we're considering intubating and ventilating a patient in respiratory failure. But airway assessment helps us to prevent complications. And so it helps us identify those patients who may be difficult to ventilate and intubate prior to proceeding. And that can help us plan in terms of that scale I was talking about a few moments ago, in terms of do we need to think about having assistance and a backup plan, and about being aware of all the potential complications. Preparation is absolutely key, even if this is an emergency procedure. And intensive care unit staff have this pathway very well worn and very well prepared, and it's something we can do very quickly. These are some of the airway adjuncts I was talking about. So on the left-hand side, you've got oropharyngeal airways, which you may well have seen used in patients on the ward. Nasopharyngeal airways, supraglottic airway devices, and obviously the bag mask that we use for rescue. You'll find all these adjuncts are at the bedside in the intensive care unit or very close by in the airway trolley. And this is something that you should be familiarising yourself with as if you come to help us in the intensive care unit. It's always helpful to know what things look like and helpful to know where things are situated. Preparing for the intubation. Most units will use a form of checklist, and this is really helpful to actually focus the planning around the intubation procedure and making sure that everybody is clear about what their role is. So it's about preparing the patient, preparing the equipment, preparing the team, and preparing for difficulty. So what we've got is when we're preparing the patient, from a nurse's point of view, we need to be thinking about is the patient in the best position in the bed as they can be. Ideally, the patient needs to be up towards the top of the bed, and they need to have a pillow that can be positioned to get the airway into optimal position. Is there good IV access with a drip running? These are all things that if you're assisting, you can be helping while the other equipment is getting ready. Also, we need to think about how will we maintain anaesthesia once the patient has been intubated. Once a patient's been intubated with drugs, in effect had an anaesthetic, we need to give them sedative agents by infusion to maintain that. And we can be getting those ready as we're planning for the intubation. In terms of equipment, I'll talk a little bit more about that shortly. And I don't expect you to remember all of the pieces of equipment that you will need, but using a checklist like this will help you, along with your intensive care nursing colleagues, make sure that all the equipment is available for the intubation person. Preparing the team, this is really important. So we make it very clear who is who. So there's always a team leader, a first intubator and a second intubator, and there'll be a nurse or colleague who provides cricoid pressure, which we'll talk about later in the talk. There'll be an airway nurse to actually assist and hand appropriate pieces of equipment to the intubator. There'll be somebody giving drugs. And also it's really important in preparing the team that we explain how we contact further help if required. So that may be escalation to a consultant colleague in another part of the intensive care unit. Wherever it's very important as we brief the team using this checklist that we know who that escalation person is and where we can contact them. And this may actually be your role to actually contact somebody if you're requested to do so. Preparing for difficulty. We talked a little bit about how we anticipate that patients might be difficult to intubate. Very rarely could we wake a patient up because the very nature of intubating a patient in intensive care, they're usually quite hypoxic, and respiratory failure, as I explained, are an issue. So if they were having a general anaesthetic for an elective procedure, yes, we could probably wake them up, but in an ICU setting, that's highly unlikely. And if you're anticipating difficulties, then we might think about going back to a bag valve mask, to a supraglottic airway advice, and it's about articulating what the plan will be if things didn't go to the original plan. So if plan A isn't working, what are we going to do to make sure that we maintain oxygenation, that we maintain the hemodynamic stability of the patient, and that we make sure that we're preventing and acting on any potential complications. You may think that this all sounds very complicated, which in reality it is. It's a complex procedure that is commonly done in intensive care, and we're all very used to it. It may be that you've never seen this before, but as a nurse, there are many things that you can do to assist during this procedure. You can explain and reassure the patient. Hypoxic patients are very frightened and they're very distressed, and actually explaining and reassure them, that can be really, really valuable in this point in the proceedings. Optimising the position in the bed, optimise oxygenation if possible, check equipment with a colleague and check your IV access, and we talked about drawing up drugs to maintain sedation post-intubation. Do you have enough help? Are there enough people around to actually assist in this procedure? If not, is there somebody else that you can call on? In addition to preparing the equipment, we need to think about allergies, appropriate monitoring, and the minimum is ECG on the monitor, blood pressure, ideally via an arterial line. And you will have had a talk around arterial lines and how we can get beat-to-beat blood pressure recordings via that. If the patient doesn't have a arterial line, then we can use non-invasive blood pressure, but we tend to set that to 2-minute cycles. Remember, we are giving anaesthetic drugs, and that significantly impacts on a patient's sympathetic drive. So hypotension and cardiovascular instability in the acutely unwell patient during this procedure can be quite significant. End-tidal CO2 is an absolute must. It's one of the ways that we can actually ensure that the endotracheal tube is sitting in the appropriate place. Oxygen saturation probe. Are all these monitors and monitoring capabilities working and visible to those who need to be able to see them? So the team leader, plus or minus the intubator. And then there's all the intubation equipment. So we need a bag valve mask, or more likely what we term as a water circuit. And this is a way of giving 100% oxygen. Most units now will use a video laryngoscope, and you will be able to see, as will the team leader, the view that the intubator gets when they instrument the mouth and are aiming for the vocal cords. Bougie, gum elastic bougie. This is sometimes described as an introducer. This in situations of slight difficulty will be inserted into the airway to actually guide the endotracheal tube into position. We always have endotracheal tubes of appropriate sizes. Generally, most units would put size 8s into ladies of an average size and size 9 into gentlemen, but ask the intubator what they want for that individual patient. So we usually have 2, plus a size up and plus 1 smaller. A syringe to inflate the cuff, some gel and some ties and tapes, and a cuff pressure monitor. So these are some of the things that I'm talking about. So laryngoscope, this allows to be lifted out of the way so that we can actually see the vocal cords and where we need to place the endotracheal tube. What we see here is an endotracheal tube with a stylet, which actually helps shape the endotracheal tube. Some people like to use, and that helps to go in the right position. A bougie, this is the long tube at the bottom there. What you see here is I was talking about video laryngoscopes, and so you see the position that the intubator is taking to actually lift the bottom jaw out of the way, and you see that the view that they've got there is of the vocal cords. So this is a water circuit or a Mapleson Sea circuit, and basically what this gives a reservoir of 100% oxygen, and we can provide some additional pressure which just assists with oxygenation while we're pre-oxygenating the patient ready for intubation. So the endotracheal tube used in most intensive care units will have one of these, which is a subglottic suction port. So secretions can pool above the cuff. This is what we're talking about here, is an endotracheal tube cuff. And what that does is that prevents leaks. So that's filled with 5 to 10 mils of air when the endotracheal tube is in position, and it's filled up from here. So that's why we have a 10 ml syringe on the intubation trolley, and there's a one-way valve in here, which means that the air is retained. The endotracheal tube, the intention is to go through the vocal cords here into the glottis. And you can't see this very clearly on this, but on the chest x-ray it should be sitting just above the carina, so just where the trachea bifurcates into your left and right main bronchus, and it sits just above there to make sure that we're getting at, when we ventilate via the endotracheal tube, that we're getting good gas exchange and air expansion on both sides. So the cuff pressure in general in an anaesthesia, it's assessed by palpating the cuff or cessation of an audible leak around the cuff. And that's the end point for inflation. And so the pressure is usually 20 to 30 millimetres, and it's generally done by a device such as this. Your intensive care nurse colleague will show you how to do this. It's really important that the cuff is inflated enough to prevent leaks, because obviously if we're positively pressure ventilating somebody and there is a leak, they're not going to be getting all of the ventilation that we require. Also, we need to be very aware of leakage of fluid around the cuff from the endotracheal tube, as secretions can actually leak down into the airway, and this can be a potentially serious form of microaspiration, and actually can add an additional level of infection to the patient. So the cuff is designed to provide a seal with the airway, allowing airflow through the endotracheal tube, but preventing the passage of air or fluids around the endotracheal tube. And the pressure inside the cuff is something that is noted in the nursing notes when we're observing the position of the endotracheal tube. So when we're dealing with patients with COVID, most units will use inline suction devices once the endotracheal tube position is confirmed. And we would use these for all COVID patients. This basically means that we can actually clear suction and secretions down the endotracheal tube without disconnecting from the ventilator. This prevents spread of COVID and aerosol generating particles, but also it means that the patient doesn't lose valuable oxygen and pressure that we're delivering via the ventilator. When we're talking about the team, we talk very clearly about who's who, and so roles are assigned to avoid any confusion. This is a very critical procedure, and it's very important that people know exactly what their role is. So we've talked about team leader and the first and second intubator. Somebody will be assigned to administer drugs, which is basically the anaesthetic, cricoid pressure, the airway assistant, and somebody who's a runner who can check and fetch help if necessary. It's very important to have a plan, even if this is an emergency or a semi-emergency situation. So the team leader will explain very clearly the plan for the intubation and ensure everyone is clear in their role. The clear plan for difficulties, and use that checklist that I showed you earlier on. It should always be used. It makes it very clear for everybody what their role is and what their role is if there should be difficulty. Even in emergency situations, you will find an intubation plan will be explained to the entire team. And you'll find that people will stand in the same situation so that they can actually see what's going on. Cricoid pressure, this is something that causes some anxiety, and basically what this means is, as you can see in the diagram here, this is the airway assistant possibly, and you may be asked to do this, but speak up. if you've never done this before, ask the intubator or the team leader to illustrate to you exactly where you need to be providing cricoid pressure, cricoid cartilage. And what you can see here is that the cricoid cartilage, by having direct pressure placed on that membrane, actually occludes the esophagus. And what that does is that prevents the patient from aspirating gastric contents during the intubation procedure. And it should only be done under the direction of the intubator, because it can actually impact on how good or poor a view they get when they're using the laryngoscope to try and view the cords. During the actual procedure, the nurse's role, it's really important that things are quiet, that there's not too much talking, that it's as calm as possible. It's really important that the nurse reassures the patient as they go off to sleep. Listen really carefully to the team leader and the intubator, and respond quickly to requests for positioning changes or additional equipment. You may be asked to time when the paralysing and sedative drugs are being given. You may be asked to call out observations. Don't do this unless you're asked to, because for some it can increase the anxiety if somebody is calling out observations when you're in a critical situation. Calm and quiet is the key. Once the endotracheal tube has been appropriately inserted, it's important to ensure that the endotracheal tube is appropriately secured. The nurse needs to observe and document the size of the ET tube and the position at the teeth or the lips, whichever is the unit preference. To note the cuff pressure and to make sure that they're aware of skin care. We confirm position by we inflate the cuff when directed, and we look for end-tidal CO2 waveform on the monitor. This is something that the intensive care unit team will be very familiar with, and that is a gold standard indicator for the endotracheal tube being in the appropriate place. Someone will check ventilation of both lungs and listen with a stethoscope for breath sounds on both sides and observing chest expansion. And a chest x-ray is generally performed to make sure that the tube is sitting exactly where we talked about before, which is just above the carina. So in terms of observations, we look at the endotracheal tube size, length at the teeth or the lips, and we note this per shift. So this is ongoing observations that the ICU nurse at the bedside will be commenting on. So we need to make sure that the endotracheal tube doesn't move. And it's really important because if in cases of sudden deterioration and increasing hypoxia of ventilated patients, one of the first things that we check is that the ET tube is actually in the position when it was first inserted, and so that's not a cause of a deterioration. Cuff pressure measurements, these are done at least once per shift, but certainly not too frequently, because that can actually impact negatively on the cuff pressure measurement. And then on a regular basis, each shift, we need to observe the skin integrity under ties and tapes, because sores and pressure damage are not unusual in the corners of the mouth and sometimes on the side of the face. In terms of how we fix endotracheal tubes, there are multiple ways. Commonest way is with tracheotape ties, and these are in a loop knot around the endotracheal tube at the point that the ET tube should be at the teeth or the lips, and that is tied around the back of the patient's neck. Important these are not too tight, and important they're not too loose. So they need to be able to ensure that the endotracheal tube doesn't move, but not so tight as it's causing compression and engorgement to the veins in the neck and pressure damage. These Thomas tube holders you may find, these go around the patient's back of the patient's neck, and the ET tube comes out through here, and this device here will screw and fix the endotracheal tube in the position that you state. These softer ties tie around the endotracheal tube, and they softly tie around the neck with Velcro, and they're adjustable. We need to be making sure that there's no pressure points in relation to the endotracheal tube as part of nursing care. So we've got a few key takeaway messages. What we can't do is explain all the in-depth issues around endotracheal intubation in the intensive care unit in 30 minutes. But hopefully I've given you an introduction to some of the equipment and the importance of the nurse's role in assisting with endotracheal intubation. The key is preparation, and that there's a set process in most of the units that you may be assisting in terms of how we manage intubation and where the equipment is held. Communication is absolutely key here. If you've not been involved in an intubation before, make sure you speak up, say to the team leader that you've not been in this situation before and that they should direct you to what they would like you to do. Make sure you communicate with the patient. That's something that you can do to really help in those moments when we're preparing all the equipment. Post-intubation care and observation. So we need to make sure that the endotracheal tube doesn't move, and we need to do that by making sure the patient is appropriately sedated, but not too much. We need to make sure that we know where that endotracheal tube is sitting in terms of position at the lips or teeth, whichever the unit you're working in uses. We need to make sure that the oral care continues. We need to make sure that the tapes are not causing impact on patient skin integrity, and neither are they causing engorgement to neck great veins. And it's about observing that things are all okay in that department. Thank you for your attention. This has been an introduction to intubation and fixation of endotracheal tubes.